Hello, everybody. At the very beginning, I wish to thank the All India Ophthalmological Society and particularly Dr. Tanuj Dada for giving me the opportunity to be a part of this wonderful initiative. I'll be speaking on glaucomatous versus non-glaucomatous optic neuropathy. So the question is, why is there this confusion and why do we want to actually discuss this? The reason would be that many non-glaucomatous causes also can result in cupping of the disc. There is a wide range of intraocular pressure that is considered normal, and therefore, higher normal pressures can even be seen in patients with non-glaucomatous optic neuropathy and may give rise to suspicion of glaucoma, and also visual field defects that may be similar in both these type of disorders. So we have overlapping clinical features in these conditions, and also that glaucomatous and non-glaucomatous diseases can actually coexist in the same person. There is adequate literature to show that almost 20 to 30% patients with non-glaucomatous optic neuropathy are actually misdiagnosed and managed as glaucoma for a long period before they are identified as something else. To consider the alternative non-glaucomatous damage or process, if the visual loss does not appear to be consistent with the disc changes, if the visual field loss is not compatible with the disc changes that you are observing, and also there may be neurological signs that may be associated with it, although sometimes they may be a little subtle. So on history, you would have possibly a younger aged patient, somebody who complains of sudden loss of vision, or the visual loss is very rapidly progressing. The diminution of vision or the field defect is far in excess of the cupping that you're observing. There is color vision abnormality, which is significant. There is RAPD without significant cupping in one eye. The ocular motility or other some neurological signs can be evident. Visual fields that show central or centrocecal scotomas, field effects that respect the vertical meridian, or there is an inferior altitudinal defect with very dense field effect in one of the hemifield, or if the temporal field is far significantly affected as compared to the nasal. Also, there are some fundus changes that can give us an idea that this process may be non-glaucomatous. While there are a lot of overlapping features, some of the changes would be the involvement of the papillomacular bundle preferentially in a non-glaucomatous process, whereas glaucoma would have very characteristic nerve fiber-led effects, which would usually be vertical. The disc pallor is fairly sensitive to the diagnosis of non-glaucomatous process, and the pallor far exceeds the cupping, and there may be diffuse or temporal pallor or loss of color. Whereas in glaucomatous process, the glaucomatous disc is excavated, but the neuroretinal rim remains fairly healthy and pink, with some focal loss showing damage in certain areas of the nerve fiber layer and the optic nerve. So major differences would be that usually glaucomatous process would be more likely to be an elderly patient, whereas non-glaucomatous can come in any ages. The glaucoma presentations is usually asymptomatic unless it's advanced with significant field effects, whereas in non-glaucomatous cases, you will have sudden loss of vision. The visual acuity is usually preserved till very late, at least the central vision is well preserved till late in a glaucomatous process, even till advanced stages, whereas in non-glaucomatous process, they may be early and severe central vision loss. Another thing is the effect on color vision, which may be significant in a non-glaucomatous process, far exceeding the amount of vision loss that the patient has. Glaucoma being usually relatively symmetrical does not show an RAPD unless advanced disease is there. But in non-glaucomatous process, usually there is significant asymmetry and an RAPD may be present. The optic disc shows cupping and rarely splinter hemorrhages. But in the non-glaucomatous process, the pallor far exceeds the cupping. And of course, characteristic visual field defects can be there in both glaucomatous and non-glaucomatous process. So there are a wide variety of non-glaucomatous optic neuropathies that can mimic glaucoma, like a late presentation of an ischemic optic neuropathy, space-occupying lesions, hereditary neuropathies, congenital anomalies of the disc like disc colobomas or disc brucins, a toxic optic neuropathy, and again, a lot of other inflammatory, traumatic, and neurodegenerative diseases. So you would consider imaging and evaluating for a non-glaucomatous process if the case presents in an atypical manner despite having some glaucomatous cupping. That would be a younger aged patient if the vision is severely affected. There is a vertically aligned visual field defect. Significant pallor of the neuroretinal rim is there. The cupping is very shallow. There is excessive loss of color vision or the presence of an RAP. The OCT changes in non-glaucomatous can sometimes be helpful. You would often see nasal and temporal loss. The papillomacular bundle loss with lower macular thickness and volume can also be a very characteristic feature of non-glaucomatous optic neuropathy. Alzheimer's disease and Parkinson's disease also have significant vertical nerve fiber loss that is visible in early stages. We'll just run through some of the cases to see how this workup can help us to understand non-glaucomatous changes in a patient who may present with suspicion of glaucoma. So this was a 52-year-old female who came to us with gradual progressive painless bilateral diminution of vision. You can see fairly significant vision defects. And repeated fields were unreliable, particularly because the visual fields were significantly affected. She was on 3 drugs and on anti-glaucoma, and the pressures were controlled. So this is the field, this is the fundus that you can see. Repeated fields were unreliable, so we went ahead to do a Goldman perimetry. But before that, the red flags in this patient is that you can see that the pallor far exceeds the cupping. The progression of vision loss is significant and despite controlled IOP. So these were the Goldman fields, and you can see there is significant temporal loss of the visual field, and there is no visual field in the temporal areas. And an MRI was done, which documented a compressive optic neuropathy. Another 47-year-old male came with progressive diminution of vision, again diagnosed as glaucoma, had baseline pressures of 24, 23, was on treatment for almost 2 years. The central vision was well preserved, both for distance and near. The cornea was a little on the thicker side, so you would say that the pressures, that's why, were appearing normal. This was the fundus again. So you can see there is asymmetric cupping with mild temporal pallor, right more than left. A visual field was done which you can see that the visual field is significantly involving the fixation in both the eyes. And in this eye, you can see in the left eye, you can see that the visual field appears to respect the vertical meridian. And again, there was progressive field effect despite controlled IOP, bilateral temporal pallor, the field effect which was suggestive, and MRI was done which showed a large pituitary macroadenoma. Again, just showing the variety in which space-occupying lesions, particularly pituitary macroadenomas, can present. Another 45-year-old male present with progressive vision loss in the left eye. The right eye was normal. You can see that the left eye is significantly affected. Left RAPD was there. Again, one would think that there is a significant glaucomatous optic atrophy in one eye as compared to the other. But you can see, of course, the left eye field was not possible. This was the field of the right eye. You can see that although one could argue that this is a superior arcuate developing, but you can see that this is significantly respecting the vertical meridian. And again, a young patient, marked asymmetry in the disease process, and fields not matching the disc. So there is no corresponding disc changes that you can see in the right eye. And this gave the suspicion of a junctional scotoma, and the MRI did reveal a chiasmal tumor. So compressive optic neuropathy is one of the most important differentials to a glaucoma we must always take into consideration. There can be multiple causes, but it's important to remember that the vision loss can be gradually progressive, painless, although the pressures may be high, but that's why a misdiagnosis of normal tension glaucoma is possible. Sometimes these pituitary macroadenomas uh, may be actually secreting hormones, particularly they may be steroid secreting tumors, and that may also give rise to a raised intraocular pressure, again further making the diagnosis complicated and difficult to identify these patients. This was a 19-year-old male who came to us with progressive diminution of vision of the right eye, followed by the left eye for 2 months with mild fluctuation. There was no family history of glaucoma. You can see the vision was significantly affected. The IOP was normal. You can see the disc was significantly pale with a fair amount of cupping and nerve fiber layer thinning. Now, this was the visual field effect. So you can see the marked dense central scotoma. He was again was being diagnosed and managed as a juvenile open angle glaucoma, but because of the predominant central visual field effects, we suspected him to be a patient of Leber's, and the genetic mutations confirmed his diagnosis of a Leber's hereditary optic neuropathy. Again, key points were early onset, marked pallor of the rim, central field defect, and of course, if you get the patient tested, there was genetic mutation positive for a Leber's hereditary optic neuropathy. So, hereditary optic neuropathy may or may not be associated with cupping. There may be a family history in the family, particularly on the maternal side, and it is a mitochondrial mutation that is maternally transmitted, can present with subacute loss of vision. The vision loss is considered to be in a step ladder pattern. But if the patient doesn't particularly notice that repeated reduction in vision followed by periods of normal vision, he may actually say that the vision has been progressively deteriorating, and again, a suspicion or confusion with normal tension glaucoma. Another 56-year-old male patient presented to us with history of diabetes, hypertension, sudden onset loss of vision 6 months ago, noticed on waking up. The vision in the affected eye was significantly affected. There was an RAPD, IOP was normal. Now, again, while we would not consider this history to be very typical of glaucoma, but sometimes the patient is not able to identify the time when the vision loss or the incident occurred and may actually complain that the vision loss has been there for some time and he's not absolutely sure when it started. So again, asymmetry you can see in this patient, you can see marked pallor that is there. So a visual field that showed an altitudinal field effect, again, you can see that a significant damage has occurred on the OCT in the in the superior RNFL corresponding to the inferior field effect. And whereas the other RNFL, the inferior RNFL is pretty normal with the normal field superiorly. So this again marked vertical asymmetry would give us the suspicion that this is an NAIO. And so, of course, sudden onset, although sometimes you do not always get it, severe vision loss, non-progressive, generalized pallor, absence of cup, although over time there may be an increase in the cup, particularly where the nerve fiber losses occurred, visual field effects that can involve the fixation early, and the fellow eye showing a small crowded disc, also called a disc. These are all signs and suggestions of an ischemic optic neuropathy. So may be sometimes confused. So ischemic optic neuropathy may be confused with a glaucomatous optic neuropathy in a non-acute stage, and late presentations may be possible, be confusing. And studies again have shown that there can be a little bit of fair amount of cupping in late presentations of both NEION and arthritic optic neuropathy. One has to be, of course, red flag arthritic optic neuropathy. These are elderly patients, although usually, again, vision loss in them can be very significant and very severe, but associated presentation of headache, jaw claudication, weight loss, fever, generalized malaise, these are features suggestive of an arthritic optic neuropathy. And it's important to identify this early because high-dose steroids are necessary to prevent the involvement of the other eye. This was a 34-year-old male who presented with recurrent episodes of diminution of vision for the past 3 years. There was a partial recovery of vision after each episode, for which oral steroids used to be given intermittently whenever the vision decreased. And also, there was a suspicion of juvenile open-angle glaucoma, and the patient was being treated with anti-glaucoma medication. You can see the fundus that the patient has. Significant pallor over and above the amount of cupping that is there. He was evaluated for NMO, and he was positive for neuromyelitis optica. The presence of AQP4 antibodies were present, and he was started on azathioprine. Again, over time, late presentation of neuromyelitis optica can present with disc excavations and can be confusing for glaucoma. In this patient, of course, the anti-glaucoma treatment was stopped, and he was continued on azathioprine to reduce the risk of recurrences of the optic neuritis. So it's important that we must have a high index of suspicion for non-glaucomatous optic neuropathy, although again, non-glaucomatous disorders can coexist with glaucomatous optic neuropathy. On follow-up, if the course becomes too rapid or the visual field effects become atypical, consider that there may be something other than glaucoma that may be happening. And glaucoma prophylaxis in the setting of non-glaucomatous optic neuropathy sometimes may be important because high pressures may be present in a small number of patients because of ocular hypertension that may coexist. And we do not want a disc that has already been affected by some other process also suffered the progressive or continuous damage of high intraocular pressure. So whenever you are suspecting that there may be some other cause, we've discussed the reasons, indications for neuroimaging. Essentially, one should consider a contrast-enhanced MRI brain and orbits. And when in doubt, always consult a neuroradiologist to make sure that you are not missing any finding in the brain that may be responsible for the visual field effect or the optic nerve changes that may be there. When in doubt, of course, Leber's requires genetic testing. You can even test for other nutritional or toxic conditions, and always beware of ethambutol toxicity, because that also presents with gradually progressive loss of vision in both the eyes. And the patients often do not consider it important to tell an ophthalmologist that he or she is undergoing treatment for tuberculosis. And of course, again, if the MRI is even slightly suspicious, get a consultation with a neurologist, where sometimes a CSF analysis may be required, because again, some CSF related changes like chronic meningitis may also present with progressive optic neuropathy as their only presentation. So to stay on the right track, get a thorough detailed history. We need to keep communicating and understanding the changes that are happening in the patient. A careful examination with keeping an open mind. Note the progression, especially if it is progressing much faster than what you expect. Do not rely only on a single piece of information like just the presence of cupping on the optic nerve head. And remember, many of these patients may have more than one disease. So thank you very much. Again, thank you AIOS and Dr. Tanuj for giving me the opportunity, and I hope it was useful.